We shall talk today about pyloric stenosis. Pyloric stenosis is a congenital anomaly in which there is stenosis of the pylorus with hypertrophy of the musculature of the pyloric and elongation of the pyloric channel. Definition of the pyloric stenosis: it is the condition of narrowed lumen of the pylorus caused by hypertrophy of the pyloric musculature. Pathophysiology and the causes of the pyloric stenosis. There is several hypotheses. First of all, the diminished level of nitric oxide synthesis result in edema leading to obstruction. Also, there is another hypothesis, which is pyloric mucosal congenital redundancy inside the lumen of the pyloric canal. And also, there is another hypothesis, abnormality of local enteric innervation in this area. Pyloric musculature shows hypertrophy without hyperplasia. For diagnosis of pyloric stenosis, there is symptomatology and signs. Chief complaint is projectile postprandial vomiting. Typical age of presentation is 2 to 8 weeks. Also, there is weight loss and dehydration. The patient must be severely dehydrated because of repeated vomiting. On examination, there is postprandial gastric wave. We can inspect on the abdomen the peristalsis movement of the gastric area. We can saw also by palpation olive sign in the right upper quadrant, which shows for us the hypertrophied pylorus. We can feel in the right upper quadrant a mass like an olive, which is diagnostic for hypertrophic pyloric stenosis. To complete the diagnosis, we can do ultrasonography and upper GI series, barium meal. Ultrasonography shows narrowing pyloric channel and redundant thickened mucosa, and it is the main diagnostic way to be sure that there is pyloric stenosis. An upper GI study must be done if we are still in doubt that there is pyloric stenosis or not. There is strength sign, impression of the pylorus into the stomach. This is a QB in which there is dilated stomach because of narrowing of the pyloric area. This is a pyloric channel, and this is the stomach, which is severely dilated. This is ultrasonography in which there is thickening of the pyloric channel and elongation of the pyloric channel. A barium meal can be done in which there is 3 ways passage of barium because of redundancy of mucosa inside the pyloric channel. Also, we can do endoscopy, which is not indicated in all cases. In endoscopy, there is narrowing of the pylorus, and you can't enter to the duodenum through the pyloric channel with the endoscope. Treatment is non-operative with atropine IV administration and stop of breastfeeding and IV fluid. Operative management is the best to do with Frederick-Ramstedt pyloromyotomy with supraumbilical transverse skin fold incision. Also, operative management can be done with laparoscopic pyloromyotomy. Preoperative preparation for operation of pyloric stenosis. We can insert nasogastric tube for decompression and correction of electrolytes imbalance, correction of fluid disturbance. Because of the dehydration, the patient has also electrolytes imbalance and acid-base imbalance. There is hypochloremic, hyponatremic, hypokalemic metabolic alkalosis, which must be corrected. The alkalosis must be corrected with normal saline or half saline IV fluid. The natrium must be corrected. Chloride must be corrected with the fluid which I said about must be added for the fluid, normal saline or half normal saline, 1 milliequivalents of potassium, which must be corrected in 24 hours. The IV fluids which must be given as bolus for 1-2 hours, then must be re-evaluation of the patient for dehydration and to do another electrolytes test within 3 hours. Then when the electrolytes is stable, we can do the patient surgery. The pH of the patient with alkalosis in pyloric stenosis always is above 7.5. When it is lowered and nearly normalized, we can do surgery. The surgery is not possible until the pH of the patient is below 7.45. Pyloromyotomy or Ramstedt surgery, we do an incision, 3 centimeter transverse incision between the umbilicus and the xiphoid process. We divide rectus muscle. We are doing 1 or 2 centimeter longitudinal incision through the anterior-superior side of the pylorus. The incision is carried out down through the serosa and muscular coat, but the mucosa is left intact without opening of the mucosa. The cut muscle is spread with the blunt end of the scalpel handle until the mucosa puts through the muscular defect, closure of the peritoneum, transversalis fascia, and the skin. And this is the operation which we are doing for the pyloric stenosis. This is the incision of the pylorus, and this is the pyloric channel. Here's how we dilate the pyloric incision, the longitudinal pyloric incision, with an artery or with the handle of the blunt end of the knife handle. Then this is the result. The mucosa is bulged without injury through the opened muscular coat in the pyloric channel, and the obstruction is removed. Then milk is coming easily from the stomach to the duodenum. Post-operative management. Post-operative nasogastric tube decompression is not necessarily unless the mucosa has been entered and repaired. So if there is an injury, iatrogenic injury of the mucosa, we should keep the nasogastric tube for at least 24 to 48 hours, but it is better not to injure the mucosa. Pain management after operation with paracetamol. Feeding are begun 4 to 6 hours after operation. Initial dextrose saline must be given. Full feeds of formula or milk are begun after 12 to 24 hours after operation. And post-operative complications which can be happen after this operation is persistent vomiting because of not complete opening of the pyloric stenotic muscles. The patient still has vomiting, and then the patient needs to repeat surgery for him. Late complications like wound infection and dehiscence, unrecognized perforation, or incomplete pyloromyotomy. The patient may has two pathologies in the same. For some patients, there is also gastroesophageal reflux, in which the patient still has vomiting. Gastroesophageal reflux mostly is treated conservatively with positioning of the patient and low milk intake with frequent milk intake. Thank you very much.